Good afternoon. Ladies and gentlemen, children of all ages, welcome to the greatest show on earth. Oh, that's the wrong presentation. Sorry about that. We're here about managing denials, overpayments, and recoupments. My name is Brian Panessa, like it says on my first slide, which I'm not presenting. I am a recovering healthcare lawyer, so I do know a couple things about the law, but I've been trying to give it up for about 20 years. We've got some goals today that I want to try to get through in the next hour. First and foremost, I'd like to try to help you understand why we are in this place and time related to denials, overpayments, and recoupments. There's a lot of forces and factors that have occurred over the last 10 years that's changed the landscape as we know it. And we're going to talk a little bit about, hey, where did we come from? What kind of things triggered these changes, and what direction are we moving? What are those market forces? The second thing I want to talk about is how those contracts that you're all in with payers affect your ability to actively and efficiently defend denials, defend overpayments and recoupments. There's a lot of detail in those contracts that you have that both can be hurtful and helpful, and we're going to talk a little bit about that today. And last, I want to try to leave you on a positive note and try to give you some good advice and some good examples on how to fight the good fight when it comes to denials and recoupments and overpayments. This is a pretty big topic as far as how important it is to payers, to providers, to health entities across the country. It's estimated that upwards of $600 billion is going to either be denied or sought for overpayment this year alone. So I mean, we're talking about a very large portion of every dollar that's coming into the health system. So why is it so big? You know, obviously it's a revenue generator for payers. It's a way for those payers to either increase their profit margin or to control cost. And so we have those effects in that revenue cycle management. And what's more important in your revenue cycle management approach than cash flow, right? And understanding how you go about preparing for these denials, overpayments, recoupments. As we'll talk about, it is regulation induced for the most part. We're going to talk about some key things, for example, the Affordable Care Act, that caused the current environment that we're in. And you'll get to see those things that in the statutes that actually cause overpayments to have risen dramatically. What's tough about denials and overpayments? Well, it costs money to defend them. You have to take time, it's people, it's energy. So approximately 65% of all practices out there don't file appeals on denials. Think about that, upwards of 65%. So my goal today, at the end of the day, is I'm hoping that you're in the 35% and that we're all going to have a plan to deal with that 35%. Because if you think about it, as a health insurance carrier, if I know statistically 65% of you are not going to file your appeal, that's a pretty good way for me to generate revenue. Just issue denials and overpayments and not have any response. We'll get a little bit into the variation on the look-back period, and I'm sure you've heard about the Medicare look-back and when you're supposed to identify overpayments. And we'll talk a little bit about that and kind of give you some up-to-date guidelines or recommendations as to what the case law actively is supporting today about what does that mean, that 60 days, and what kind of obligations do you have to make sure that you're monitoring for overpayments. All right, so how do we get here? So if anyone was fortunate enough to be around in the 90s, as I was, and dealing with healthcare issues, you will remember that denials ruled the roost. Denials was the name of the game. You really very rarely saw overpayments unless it was a straight fraud type application where the services weren't performed or there was some element that was truly fraudulent. How did we defend these denials? Well, typically your basic response was to send the medical records in, right? Our medical records are going to have the documentation that's going to allow us to get paid. And fortunately, in the 90s and early 2000s, that was successful. traditionally anywhere from 50 to 70% of the time. By sending those medical records, you would get paid. Unfortunately, as we'll see, that's no longer a good strategy as a starting point on how to deal with denials or overpayments. So let's talk about the good old days. You know, like it says, who doesn't miss being able to push somebody in the pool and not worrying about their cell phone in their pocket? I do. The good news is I think with the iPhone 10, it's waterproof, so now your friends who have those, you can now push them back in the pool. So it's come full circle. What is under in the False Claims Act 2009, pre-2009, really what was required was that intent. A false statement on your provider's or your practice's part or your organization's part. It was an active action of you doing something to try to prevent having to pay money back to the government or trying to obtain money. The important key there, distinction is there is an active event, something that you did intentionally. So that's a little bit about the governmental application there. What about the commercial carriers? How are they managing that process? So when you're looking at a denial strategy pre-2012, really the goal was the more I deny, the more revenue I get to keep at the insurance carrier level, and so the more money I make. So it's a very simple equation. They take in premiums, and then they try to potentially pay as little as possible or deny, and that creates that separation. So the incentive pre-2012 was to go ahead and make sure that we had our denial processes as payers as tight as possible so that we could create that revenue gap. We could make that profit, and that was the way the system was incentivized, is to create the spread to be able to be profitable. Obviously, increased denials meant increased revenue. Really not big on the overpayment strategy at that point. We really didn't see that come into full bore. I have a train in the back that's going to take everybody around if you get bored with my speech, so don't worry about that. Yeah, it is not Disneyland though. I think it circles like 6 bars in the area, but so basically the overpayment strategy was, hey, once again, just like the federal government, we're talking about fraud cases and how they can potentially obtain those monies back. So what happened? How did we suddenly go from a denial aspect to then moving towards an overpayment aspect? The Affordable Care Act caused basically a fundamental change in how insurance companies viewed that payment process. It basically did 2 things. One, it took it from action to inaction. So basically you were, instead of having the state or the federal government having to prove that you did something wrong and you intentionally did it wrong, now your inaction to do something could cause liability, which that's a big, huge distinction, because basically they don't have to prove that you did something wrong intentionally. Now they can just say you should have known better and you shouldn't have done that, even though it wasn't an intentional act. So basically it was, hey, you didn't get this medical necessity right. It could now lead to liability under the Federal Claims Act. So that's a big paradigm switch. What's Medicare? When you're looking at overpayment, obviously Medicare rules are typically a nice starting point when we're going to talk about what commercial carriers do, how are other organizations going to look at it. And so here, if you look at what our Medicare final rule says, it says overpayment is identified when the person has or should have, through the exercise of reasonable diligence, determined that the person has received an overpayment and quantified the amount of overpayment. This was definitely written by a lawyer for sure. Okay. And I can tell you the word reasonable diligence, if I had $1 for every time lawyers got paid to argue about reasonable diligence, we could probably pay off the debt for the country. So it's a situation where these are terms of art that are put into statutes so that there are arguments both sides. But what is reasonable diligence? That's really been starting to be litigated over the last 4 or 5 years of what is really required from you or your practice. What kind of things are they looking at? Oops. So examples of overpayments. The first thing you need to do when you're looking at an overpayment, and we're going to just talk about the bad stuff now, so we'll talk about the good stuff later, but let's say that you have an overpayment situation. What are you required to do? Well, first of all, you're going to have to identify that you have one. Some examples: duplicate payments, obviously non-covered services, medical necessity, lack of documentation, all examples of things that now are considered to be potentially ripe for overpayment. Okay, we've identified something. Now we have to investigate. I don't know if anybody knows anything about Hogan's Heroes, but Sergeant Schultz, he always said, "I see nothing." Interesting approach, and sometimes people take that, but really when you're investigating, you should be taking a look at what types of things in your medical records are going to give rise for that liability. So you have reactive. You have your reactive investigation. So reactive just means, hey, I received a letter from somebody, I received information from somebody, and I need to take action. It could be the OIG, it could be your MAC carrier, it could be a managed care organization letter. Basically, it's when somebody takes an action upon you and says you've done something wrong, your duty to investigate is much heightened. So that's kind of a pretty well understood thought. You get a letter, hey, we've got to look at it, look at the patients, see what's going on. It's, in fact, a lot of times in today's day and age, I don't know if anyone's received a letter asking for money back and they extrapolated across your entire patient population for a bunch of years. And those type situations are especially important to investigate because of the fact that not every patient's the same, not every medical record's the same, and you should always be looking to see, can I limit anybody's extrapolation? And for those of you who don't know what that process is, basically these third-party entities who are seeking these monies back from you for overpayment say, we looked at 10 of your 400 patients and you had this in these 10 patients, so we're going to extrapolate that rate over your entire patient population. It's a way for them to ratchet up the amount that they say you owe them back. How about proactive? Proactive's the tough part. That's what we're going to do when nobody's looking, when nobody's telling us what we should be doing. That's when you are taking steps proactively to investigate things that you find internally. I think you'll find when you talk about reasonable diligence that those items are going to change as it relates to the size of your entity. What may be reasonable for a 4-doctor specialty practice might not be reasonable for a health system. So really you got to kind of look at where you are in that paradigm and understand what kind of actions you need to take. Once you do identify and you've done your investigation, and unfortunately you have to go ahead and report those instances. Reporting is obviously going to be, there's a process through your MAC carrier in the event that you do have an overpayment. Make sure you read the rules, make sure that you follow the process. This is where a lot of time comes in that 60-day rule where people say, okay, they've asked me, Brian, as a lawyer, should I go ahead and report this? I have 60 days, but I haven't really investigated it. The 60 days doesn't mean 60 days. It truly means 60 days to identify something and then potentially investigate and then determine an amount. So when you ever think about this, and if you do have a situation with Medicare where you're having to be subject to an overpayment, just understand that, if I was to give a time frame, 6 months is probably too long. 60 days is probably always going to be okay. But if you're discovering it, investigating it, identifying it, reporting it within that 3 to 4 month cycle, I think you're always going to be within that standard as long as it, absent fraud or something of that nature. Once again, report to the appropriate person. The things that are examples of those reporting is, hey, I have a lack of medical necessity, incorrect CPT codes, duplicate payments. Some of these things are really tough to report on yourself, right? And I'm not suggesting that you do. You need to be real certain that you don't have, like, for example, medical necessity. The easy examples are, hey, I had duplicate payments, right? That's something you face all the time. And those are examples of having to repay things that is just standard in the practice. Refund, not like the good refund you get from the IRS, more like the refund you're giving to the government. So who do you pay it to? Once again, to your intermediary carrier. Use their forms, use their processes. Typically, as a point of practice, if you are subject to having to give a refund, ask your carrier for a payment plan. It never hurts to ask. A lot of times, I've seen clients that have, $70,000, $80,000, $100,000 repayment, overpayment issue, and they will try to suck it up and come up with that $100,000. Typically, those carriers will work with you, and you can establish a payment plan to maintain your cash flow. So always be in the back of your head. Don't forget to ask for time if you do run into one of these issues, whether it's a commercial payer or a state or local payer. So the medical loss ratio rules. So this is really where the rubber hit the road and made everything change in terms of going from denials to overpayments for the vast majority of how insurance companies are going to reserve their margin or their profit. What the MLR does is it allows the insurance carrier to, well, it doesn't allow, it requires the insurance carrier to have to pay back any monies that they take in premiums that are over a certain percentage. So that being said, there's two facets that they're allowed to look at. They're allowed to account any of their medical expenses that they pay in that ratio, and then basically also any quality improvements. So there's basically a bundle or a pool of money that they're allowed to say, yes, this is a medical expense. All the other stuff is limited to a percentage. So basically, when the MLR was identified in the ACA, they said between 80 and 85% is depending on the carrier, depending on the situation. That's going to limit to basically what their gross profit is. So traditionally, insurance carriers would make about 30 cents on the dollar by increasing that denial rate. Well, it was very interesting that the moment that the MLR went into place, denials went down by 48%. I know that on that specific day that everybody in this room got really good, and all of a sudden we all got 50% better than we were before, but it's really the insurance company driving that denial rate down. And it's pretty simple economics. If I get paid $1, I pay out $1 and I get to make 15 cents, or I don't pay the dollar and I make zero, it's pretty easy to understand that they have incentive now to pay versus incentive to deny. So it's important to understand the dynamic. So what's that do for us? How does that take us to that next level? Well, payments go up. Believe it or not, payments went up. Obviously, denials go down, payments go up. It's kind of counterintuitive that it would have that effect, but it does. As we said, the payments were supposed to cause the premiums to go down. Because if you think about it, if I limit insurance carriers' margin to 30% or to 15% versus 30%, then that 15% should go back into the system somewhere, because they either have to pay it to the entities out there, or they have to pay it back to the folks who paid the premium. And that's what happened in some of those years. I don't know if anybody here had that happen to them, but oftentimes the premiums were getting paid back. Excess premiums are going back to the actual payers of the premium. However, didn't take long for them to understand how to create a loophole. And it wasn't a bad idea. The idea of saying if we limit the amount of money that they can make, and more money will go to healthcare, reduce costs, it makes sense. The problem is you better circle around and make sure you haven't left a loophole. And unfortunately, they left a really big loophole called overpayments. So what happened was, not only can those health expenses and the quality improvements go in there, but the cost of having to collect overpayments went into that medical loss rule. So the insurance company said, you know what, that's great. You know what we're going to do? We're going to create subsidiary entities that go ahead and go out there and collect overpayments from providers, practices, entities. And so, for example, I'm sure everybody here has heard of Optum. They're owned by United Healthcare. Well, it's interesting, they make about 70% of the net profit of the entire United Healthcare. And I'm not just picking on them, they all have subsidiary entities. But what the plan now is, we'll collect an overpayment, we'll take a contingency fee on that overpayment, call it 40%, 50%, and then that money goes into that subsidiary company, and it doesn't have anything to do with what's happening over there on the medical loss rule. So they said, okay, we're just going to take our profit over here versus taking it over there. So they didn't fix that loophole. So now insurance companies, instead of denying cases, they've said, here's our incentive. We should go out and manage overpayments. And if you've looked, the level of overpayments have skyrocketed in the last 5 to 8 years. I mean, tremendously since 2012. So you have to understand that as healthcare entities, that is the main business model and focus of the carriers, your payers that you're working with on a daily basis. And when you understand that, then you can start to plan for their business model. So commercial payers have some of the same reasons that federal payers have for handling overpayments. Medical necessity, lack of documentation, pre-authorization, that handles about 15% of all overpayments. Coding errors, allowables exceeded. So if you're gonna, as an organization, if you're going to try to address some of these issues, there's a lot to bite off, right? I mean, these are denials and having the process to manage the appeals. Start out where the major problem areas are, right? So medical necessity, lack of documentation, that's really where the vast majority, we're talking 65% of every overpayment and denial now is related to medical necessity and lack of documentation. That's payers getting much more sophisticated about how to manage what you're getting paid. This is not a situation where, hey, you did too many doses or you did this. This is a situation where they're looking through the peer-reviewed literature and trying to find ways that your expensive procedure doesn't fit within their medical policy. And so it's a much more sophisticated practice. Obviously, since it's 65%, we can see that's where the vast majority of those recoupments are coming from. It's because of that, these organizations that have come up, like the Optum and a bunch of others out there, that they become little mini experts on all sorts of different areas. And what they try to do is, once again, enforce those medical policies upon the practices. And really, when it's changed, it's not that the practices or your entity is not delivering the service. That's not the issue anymore. It's you delivered the service, but you didn't get point F out of 26 points. Because you didn't get point F, we're going to take that money back. So it's like having an investigator trying to figure out how they can take money back rather than go, hey, they delivered the service, we need to pay. And like I said, lack of documentation, guys, I mean, that's really, you don't have medical necessity if you don't have documentation. And I know you've probably heard, document. I'm sure everything you've sat in pretty much is going to tell you to document. I'm going to try at the end to give you some advice about how to document and what specific things you can do to prevent or perhaps at least be able to deal with those overpayments and denials. So we've talked a little bit about where we've been. We've talked a little bit about how we got here, what those payer forces are that are causing that overpayment model. And we've talked about medical necessity being one of those hot ticket items. The American Medical Association defines medical necessity, and they give some guidance on that. For the most part, if you look at it, it's preventing, diagnosing, treating an illness, injury, disease. But really where the meat of this medical necessity language comes in is when it says, in accordance with generally accepted standard of medical practice, A. B, clinically appropriate in terms of type, frequency, extent, site, and duration. Okay, right there, you've got 5 different items. If I was a highlighter, I'd be highlighting those because that right there is where the vast majority of your medical necessity challenges are going to come. And it's well defined. Then it's going to be tied directly back to whether you're following the generally accepted standards. Honestly, in my practice of the law, I've not seen C really ever be applicable. I don't know if anybody else in the room has, but I've really never seen a health insurance carrier or a federal government or state actor argue that. But when you're looking at that, your type, your frequency, extent, site, and duration, if you focus on those items, you're going to be in a good spot when you're talking about, hey, what are they going to look at first? What's the low-hanging fruit for somebody who's recouping overpayments? Those terms right there, they spell it out pretty clearly. That's your low-hanging fruit. So let's talk a little about payer contracts. I'm sure like him, everybody's over the details, but at the end of the day, that's really where you're giving your entities, your practices, you're giving your rights and agreeing on what your rights are between you and the payer. And I know that I'm not going to sit up here and say, well, you guys can negotiate all these terms out of your contracts. I understand that a lot of those contracts are standard terms and you're going to have to live with those. However, it's important that you at least understand on your medical necessity requirements, there's a couple different ways that insurance carriers will put that out, whether it be, like I said, federal, state, or commercial, typically through a medical policy manual that they'll post online, or potentially the provider manual. Most of those items are tied back in your contract directly to a contractual obligation that you have with that carrier to follow those specific rules. Interestingly, they typically contract with you and then they give themselves the right to change it at will at any time without your approval. So realistically, think about that. I can change my rules at any given time, and you have to adhere to it, and you've already agreed to it in your agreement. It's kind of tough. Some policies will say that they have 90 days for you to review those changes and make sure that you have an opportunity to talk about it. But I can tell you, I've very rarely, if ever, had seen somebody go and say, hey, I don't agree with your policy change, and them say, well, okay, we'll exclude you. That doesn't happen. It's basically like, you know about it, it's changing, do something about it. So there's really not a lot of bargaining power in that policy change aspect, but it's really important because those are the rules that they're going to utilize to come take that money back or deny your claims. As I said, most of these policy changes are just happening online. So you won't even know that it's happening, and it's happening every day. There's tens of thousands of medical policy changes that happen every day, every year across the country. So many every day that are affecting your practice that you don't even know are happening. How do you find out about these? Typically, it's because you're getting an overpayment request or you're getting a denial potentially, and that's usually the standard way for people to know that something's wrong and somehow their medical records aren't matching up to the medical policy. But it's always retrospective, and when you're retrospective, you're going to have the time from discovery of when you realize it's happening to when it started, and all of that exposure in between is going to be unlimited liability based on what your utilization looks like. So you typically get about 30 days to object to overpayments. That's pretty standard in most contracts. The tough part is most of your contracts are going to allow the insurance carrier to withhold payments for services that you're rendering that have nothing to do with the patients that there's a contention that you've done something wrong. So if you think about that, if I'm a payer, what a great system that is. I can change my medical policy. I can then say I'm going to take the money back. And then at the end of the day, I'm just going to hold the money that I owe you already, so I don't even have to worry about going and getting the money. I'm just going to stop paying you for the services you're delivering for the other patients. So it's a pretty good process related to how they can manage that money. So what do we do about that? So the payer contracts, you need to look at your individual payer contracts. There are some good things in those payer contracts. I handled a matter that there was a policy change and the individual had worked the pre-existing policy and done it for 12 months. And the company came back and asked for about $180,000 back. And the posting change was done online. Interestingly, because the payer contract was old, hadn't been renewed, it required medical policy notification in writing delivered to the office. So even though you may have a situation where you're dead to right, and yes, they might have good arguments, look at the underlying contract. They might not have done what they should have done, i.e. notified you in writing versus just posting on a website somewhere. So it's always important to look through your agreements when you're facing one of those situations so you can make sure you actually owe the money. If you can utilize their medical necessity definitions, it's very important. I think one real key, though, is to make sure that what they're saying matches the peer-reviewed literature. Oftentimes, we'll see overpayments in areas where there are higher ticket items. And I've seen on many occasions where they will overreach, change a policy that's not supported by the medical literature. And even though they have a contractual obligation in most contracts to make sure that they're making decisions based on scientific evidence and peer-reviewed literature. So if they don't have that, if you're facing that situation, make sure you do the underlying research to identify whether or not what they're asking or what they're saying is required is actually required and supported. Sometimes, fortunately, there are some state statutes that can take effect. I've got a link here, so you guys, if you download the presentation, you can utilize that link and check your own state. But these statutory requirements will limit the commercial carriers or Medicaid, MCOs, ability to be able to recoup that money from your existing patient population that you're seeing at that time. Florida is a good example. They have a statute that requires a signature from the practice after there's been an overpayment model. So in that case, if you send a letter saying I dispute the overpayment and I do not authorize you to withdraw it from my existing practice, even though you've contractually obligated yourself to that in their payer contract, the state law supersedes and they will not be able to. They'll be in violation of state law if they go ahead and take that from your existing patients. So that's a case where your state law is going to cause your insurance contracts to not necessarily be in effect, or they'll have been waived by the insurance carrier. Another good piece, if you are getting any of these denials or overpayments from your Medicaid MCOs, make sure you look to the underlying state guidelines. Obviously many states now have gone to having a full MCO process when they're delivering Medicaid services. But most of those states delivered those services before they had those MCOs. They have medical policies in place. They have the information. Very often, the policy of the state does not match the policy of the MCO. And there's a nice little one-liner in the vast majority of those contracts that say, hey, if there's a state policy or a federal policy that's different than what we're telling you, the state policy rules or the federal policy rules. So take a step back and look to see, is that the actual policy of the state? And I've seen it time and again where the state policy is not what they are contending or what limitations they're trying to put on as the Medicaid MCO. So make sure you take a look at that. Other strategies. All right, when all else fails, complicate matters. So the insurance companies, just like all of us in our businesses, we're going ahead and we have a process, and when something interrupts that process, it makes it more challenging for us to deal with those issues. There's certain challenges that you can make that are going to allow you to be able to defend these matters and also be able to put the onus back on the insurance carrier. We'll go through ERISA challenges a little bit. It's a very growing area in denials and claims. Independent medical reviews are often identified in your payer contracts. So that's one application. State fair hearings, if it's a Medicaid issue, it's a denial. Your patient it typically has a right to have a state fair hearing, and you can represent them in those for the most part in most states. Some states have separation between an independent third party who's going to review those claims. So it's important to, once again, look at the payer contract, see what your rights are to be able to manage that. A very non-used section for pediatrics. If you're seeing pediatric patients and you're having a problem, your EPSDT services. Most people don't look at standard services that are given to a child as EPSDT services. They think in their mind, oh, these are just well visits or whatever. Under the statute, treatment, any type of treatment that's given to a child 21 or under is going to be subject to EPSDT services, absent maybe some behavioral health. But that being said, the great thing about that is it's a trump card. So that basically, EPSDT services says, if you're seeing a kid under 21 that's on a Medicaid program, Social Security Act supersedes every medical policy out there. So you really at that point can go, okay, you know what? These are the set of rules that apply, not necessarily your rules, insurance carrier. So make sure you take a look at that. ERISA. Basically, ERISA challenges is basically 80% of all commercial plans that you deal with are employer-based plans. And so ERISA is a body of federal law that applies to employee benefits. Denials are considered adverse benefit determination, and that brings inside the scope of ERISA, and it brings in federal law. We're going to see an example of a letter to give you some example of language that you can send when you have that denial or that when you have that overpayment, that recoupment attempt. The important part to know is that there are certain specific guidelines that ERISA lets you follow. So like we said, hey, how do you make it more complicated? Make them follow the federal rules versus having to follow their own little particular rules, because that gets it out of their system. They're not used to doing that. I believe Cigna got hit for $7 or $8 million for that specific issue of not being able to comply with that federal law. And so now if you do get a denial on overpayment, you see some additional language on your Cigna denials because they understand now that they have to comply with the law. It is a complete or partial denial, so you don't have to have a full denial. If they only give you a certain amount of it, it's still an ERISA issue if it's an employer-based plan. Recoupments, overpayments, if you're out of network, you can still use that benefit. If you're in network, traditionally there's a case that just came out about 10 or 11 months ago that says an overpayment, you can't use ERISA on an overpayment when you're in network because your contract as the healthcare entity is with the payer, not with the patient. So the patient, you say to the payer, hey, I'm not going to pay, once you pay me, I'm going to release the obligation for the patient to pay, and then a year later, the insurance company takes that money back. You still don't have any right to go against the patient. And so you can't, when you're trying to stand in the shoes of the patient and say, hey, I've got this right, they don't have any right to go help you with the overpayment. I would suggest a fix to that problem. You guys all have, obviously, your assignment clauses that you have in your policies. You have your patient sign. Look at trying to add some language to those assignment clause that basically says, in the event of overpayment or recoupment, that you agree to be responsible and assign those rights. It's clearly not been litigated, but at least you're giving yourself an opportunity to still be able to apply the law and send this letter that we're about to talk about. Basically, this letter was specific to a client, but it's generalized enough that you can fit the terms into your specific matter. What rights are available under ERISA? Well, there's quite a few rights. Basically, it's a right to a fair hearing, which most carriers are going to give you that. They're going to give you the process by which you can appeal. But more importantly, there's some time frames. And so, when you can change their time frames, for example, they have to give you 60 days to file an appeal. How many times have you seen a letter from a commercial insurance carrier that says you need to respond in 30 days? Well, no, I don't. This is an ERISA plan. This is your denial. I'm going to send you a letter and say, hey, I've got 60 days by federal law, and they can't do anything about it. Now you've changed their model, right? You've made it a little bit different for them. So what kinds of things are adverse benefit determination? Experimental investigational, that's an adverse benefit determination. Pretty much any reason for denial is going to give rise to an adverse benefits determination. So once again, there's some language in here, and like I said, feel free to utilize the language. It's a good starter for you to build your letters out of, and that was kind of my goal, is to give you that tool. 30 days. They have 30 days to give you every document that they utilized in their decision-making process to do that denial or that overpayment. I mean, that's pretty big, because what do you get now? You get an EOB, and the EOB has a code or two on it if you're lucky, but oftentimes they didn't get anything. So the good news is there's some language in here that it's right there in bold that I would suggest when you are sending this letter, make sure you include it. And it's going to allow you to be able to require them to give you those documentation. And there's significant penalties when they don't give you those documents. Traditionally, the fine is up to $110 a day. And federal courts all over have awarded tens of thousands of dollars related to insurance carriers not giving the documents that they are basing their decisions on. And so I think it's a good way to effectuate that change of their process and say, hey, no, you're required to do this, and there's going to be a financial repercussion to you, insurance carrier, if you don't. So there's some examples about the case law. So we kind of talked about where we've been. We've kind of talked about, the contractual obligations. Let's try to talk about now, hey, what steps can we take to make this process better in our organization? How do we manage it? Now we know, how do we manage that? So what do we all have to agree on before we can start making a roadmap? Medical policies are constantly changing. We have to agree on that. That happens every day. You see it every day in your practice. They're going to use that medical policy to change the underlying things that you're going to be required to show in your medical record. Payers are incentivized to pay providers rather than issue denials. So at the end of the day, they want to pay because they want to make the 15 cents. And they know that they're going to have the opportunity to take that money back 6 to 12 months from now. So as long as there's not one of those statutory limits that we talked about, the 6, 12 months, that look back period that they're allowed to go back and take monies back. And by the way, that's an important issue too. Always make sure you know what your state allows. It'll typically, once again, be in that prompt pay law. How far back can they actually go? And I've seen insurance carriers time and again go twice as long as they're legally allowed to go, because at the end of the day, as the payer, or as the provider or the organization, if you don't contest it, you're going to pay that money back without effectually taking advantage of the law and limiting that. So medical policy, who's monitoring that for you, right? So I've been around the country. I've asked hundreds of different healthcare entities about this, from DME to practices to ambulatory surgery centers. The one response I get that's consistent is, "Oh, my biller does that for me." And that response always means that no one's doing it for you. Not that billers are not capable of doing it, but billers don't have the ability to look at the medical necessity, understand what's in your documentation, and cause you to make changes to what you do. That's not what they do. They push your data through a scrubber, through the clearinghouse, and you're going to catch some stuff. But remember what we said 65% was? Medical necessity, lack of documentation. Is any clearinghouse going to catch that? None. Okay, so we know that that biller is not going to be covering you for the vast majority of what's changing in your market. The next response I get is, well, my EHR company, they're changing all the time, and they're gonna make those changes, and it's built in. Well, there are ones that get smarter over time, but they get smarter because people have been denied, people have had overpayments, and so eventually when they get enough of them, they make rules. But at the end of the day, they're dealing with so many vast different types of providers, different types of entities, that what you'll find is if they do make changes, they're about 180 days behind when a change actually happened. And there's so many changes that they don't have the ability to monitor and manage those changes. So you're not getting that in your EHR. So if you're not getting your EHR, EMR, and you're not getting it from your biller, pretty much just leaves one other person to do it, and that's you guys. It's the folks who are actually in the practice, in the organization, managing those changes. And like I said, at the end of the day, it's a bad strategy to go, I'm gonna be okay with learning about it because somebody's sending me a letter saying I gotta pay them back money. There's a better way. So what is that better way? Our goal is, let's develop a policy to track changes. How do you manage that in your practice? This is basically a sample policy that you could implement in your practice about managing those medical policy changes. Don't have to start off doing it all in one day. I would suggest looking at your highest paid reimbursement codes. You can look at things that are high dollar and also high volume for your practice. Check on those things once a month. Put a process in place that's going to say, okay, we're going to review these 10 codes every 30 days to make sure that the 5 or 6 or 10 carriers that pay us, that make up the substantial amount of money, that we're at least looking at those so that we can set a time in that says, well, we're not going to be any later than 30 days. We might have missed the 30 days, but we're not going to be any later. So at least you're giving yourself a chance. Remember when we talked about being proactive in the investigative process? That's a really good event to be able to say, how are you being proactive to make sure that you're keeping up with things that you're supposed to be keeping up with? How about the fact that you're monitoring medical policy, which is the vast majority of why you're going to have an overpayment request? That's a pretty good piece to say, hey, listen, this is my preventative measure. I am being proactive. Once again, you really want a systematic approach. We say calendar it, create a log, create a system in place so that you guys can figure out how to identify the times when it's going to change, and then not only, okay, so we've figured out something changed. This comes the hard part. Once you know something changed, then you've got to push it all the way through the system, right? So, because, doctors are adverse to change, right? So, getting them to going them and saying, hey, you got to include this in your medical records or because this just changed, that's tough, right? I do think, though, you could use your relationships with your EMR, your EHR to push those changes through. If you find a critical change, call your person at your EMR company and say, we need to have this put into our medical record. Make them do the work, and then the doctor has to fill out that box in order to be able to continue to go through. So, I mean, you can utilize your existing resources to make it happen. Implementation, and that's kind of what we were talking about. How do you effectively implement those processes? It takes people. It's going to take time, and you have to realize how important it is to your bottom line to commit those resources. You will get that value back if you commit the resources. Obviously, a log, once again, is a good way to track it. What you'll find, this is interesting, when you go to see a policy change, they'll go ahead and change the insurance company will change the policy, but then they will not give you they won't give you the policy that was changed from. So you could say, oh, okay, there's a policy change. If you didn't track what it was before, and somebody asks for recoupment back, you're sitting there with an existing policy that was changed, but have no idea what happened before that time. So I think there's tools that you can utilize. A log is one. I think there are tools, though, that you can utilize that will allow you to be able to track those relatively easy. So what do we do with our newfound information? We know that medical necessity and lack of documentation is where we're going to lose our money. Where they're going to take our money back. So that begs the question, okay, let's go ahead and fix those two things. That's primarily what we need to fix. One option, do nothing. Just respond to overpayment requests with large checks. That's not a good option. Unfortunately, about 65% of the people, that's their option. Don't be that person. Third-party consultants can work. Auditors, big data analytics, they usually can find those patterns in your data to be able to draw it back. But once again, it's typically retrospective. It's not going to tell you, hey, something's happening, you haven't gotten a letter yet. So you really need to, typically that's a pretty expensive event to manage the process in that way. Not that it's not worth it, but at the end of the day, I believe there's more cost-effective ways to manage that process. Get proactive. Okay, establish some kind of policy. That's step one. Even if you just have the policy and then you take a time to start trying to implement little pieces of it, I think that's really important. If you get a denial and you get an overpayment, look at the medical policy before you send them the records. What always happens now, we did that 20 years ago. Sent the records in, off and running. We got paid 60, 70% of the time. Look at your medical policy when you get a denial. Look at it before you get an overpayment. You should never send your medical records to an insurance carrier, the federal government, state entity until you've reviewed the medical policy and see how that stacks up to your medical records. Because the end game is my medical records equal all of the medical policies out there. If they do that, then you're going to be locked solid when it comes to managing denials and managing overpayments. It's my one shameless plug here is if you use medical policy change monitoring software, we actually created a company to be able to monitor all the CPT codes across all insurance payers to make sure that we know when things change and also track it. It came from a need in our ancillary company, and so there are tools out there like ours that will help you manage that process and give you an item of being proactive. So I would suggest if it's not us, even if it's establishing your own process, your own policy, make sure you make something happen related to how you're going to track these changes. The really good news is that I finished early, and so everybody's always happy about that. If If you, I think they indicated that there's some kind of speaker review. So if you liked what you heard, I'm Brian Panessa. All 10s would be great. If you didn't, I'm John Smith in Exhibit Hall B. A is an apple. Thank you.